Hi, this is Roger Green, host of the Surfing the Mesh Tsunami podcast. This week we are offering 5 conversations from episode 13, our preview of Global Fatty Liver Day 2023 from Global Liver Institute, with Jeff McIntyre, Mike Patel, Louise Campbell, and me, plus from the vault, a look back at our wrap-up coverage of International NASH Day 2023. This conversation focuses on what happens after or around patient screening, addressing the challenges caused by using GLP-1s and dual incretin agonists to treat concomitant conditions before looking at the patient's liver, and then the opportunities that can come from on-site scanning and immediate feedback. Jeff McIntyre says the popularity of GLP-1s and incretin agonists could, quote, lead to a tricky couple of years, unquote, if the explosive use of these agents results in decreased willingness by patients to participate in clinical trials and or decreased demand for fatty liver drugs from patients already on semaglutide or tirzepatide. Generally, he expresses a concern that all this will lead to a decline in focus on the liver at exactly the wrong time. Louise Campbell discusses activities in her 2 home countries, UK and Australia, after which Mike Patel asks her about how she uses scanning results to drive patient education. She notes that the focus should be on poor liver health, not liver disease, and reports data in her possession showing that 33% of Australians who believe they are healthy have poor liver health, and most of these are postmenopausal women. As we know, and Louise discusses, poor liver health is more likely to lead to cardiovascular death and extrahepatic cancers than simple liver disease. Global Fatty Liver Day, the event previously known as International NASH Day, is the preeminent patient advocacy event on every year's calendar. This conversation whets our appetites for this year's event, so just sit back, listen, learn, enjoy, and when you're done, join the dialogue in our LinkedIn discussion group.
Jeff McIntyre.
This could be kind of a tricky couple of years, or it's going to be a tricky couple of years as well, because we know the correlation with, obesity and fatty liver disease. And while we're having this conversation about drug development, about medication development, about reimbursement, there is that same very high level, very detailed conversation going on with the anti-obesity medications as well. One of them just recently got indicated for cardiovascular disease. And so I think there is a question of, in the same way that some are concerned that having a medication will lead to a sudden decline in the numbers of patients that are willing to sign up for clinical trials, I think there is also some concern that if we have anti-obesity medications that are moving forward, will there be the need for the early stage fatty liver disease medications? Granted, some of them are the same, but the distinction there is that we lose the focus on the liver, I guess, a little bit. And now some may say by any means possible, but we do have to be a little more intentional in terms of how we are going about this, I think.
Roger Green.
Louise, please share general reactions or take us to either the other side of the pond or the other side of the world, depending on which of your 2 residences we're talking about. And how does this look different there, since this is, in fact, a global fatty liver day and a global set of issues?
Louise Campbell.
I think the guys all raised absolutely valid points throughout. One thing that drives attention is when people front up at primary care in numbers saying, I have this, I want this. And awareness is absolutely key. Liver disease is a small portion of poor liver health. We have had, on the whole, for the majority of patients, an awful long time of poor liver health. So we now need to start recognizing what poor liver health, for me, is driving. Poor liver health is driving cardiovascular disease. We have FIB4 also being attached to cardiovascular risk. We also know that poor liver health is accountable for up to 70% of those who develop type 2 diabetes. Some of those will have liver disease, end-stage HCC with that. The same in the cardiovascular community. So for me, it is screening for a different reason. It is screening to identify poor liver health as a driver of multiple other diseases, some of which are the biggest killers in the world and are part of a liver poor health syndrome. Now, that is a disease. Because it's not fibrosis does not mean it's not disease. And I think we have to broaden our net to say that we are screening you for liver health to reduce your cardiovascular and find where your liver disease is. Because if we've screened that volume of people to identify their risks, then we will find liver disease. At the moment, we're never going to find it in the volumes that we want. But I can assure you from my figures here in Australia and my data in the UK, some of which I'm going to talk about when I'm at EASL, is that at least 33% of the Australian population who think they're fit and healthy have fatty liver. Very few of them have liver disease. So the screening for liver disease question is poor. All of them were women who had advanced fibrosis, and most of those women were postmenopausal. So again, these are smaller numbers, but these are general population. These are not enriched populations. UK data, almost identical. If I subcategorize into the smaller figures, the ethnic minorities and the populations within the country, I've yet to find somebody from Nepal who doesn't have fatty liver. I've yet to find the majority of Indians who, in either country, who don't have an element of or a family history of. So I think there are significant pockets within that we know when we enrich those populations, that data. But I think there's a real element of giving people responsibility for health and saying, I've heard about this condition, I want to be screened for it. But if we just go, we know that patients tend to go to the GP, I think it's 2 to 5 times before somebody starts to screen their liver and think about livers. They attend on more average because their symptoms are so non-specific. But go into that, that's a policy decision. That's a countrywide decision to raise the level of poor liver health and liver disease affecting X, Y, and Z. So that also has to come into it. FIB4, if every GP had access to FIB4 or the ELF, we would then still be needing a second degree test in the community, which we don't have, to screen them out for the naives and everybody else to enrich that population a little bit more strength. And I think we're starting to bring that in the UK with access to FibroScan in community care. The difficulty with that, there's no funding given to primary care to do this. There is no reimbursement system that is open for the next 2 years to allow somebody like ourselves to go on to be contracted in to just provide you with 14 scans once a year because you don't have the finances to buy a machine, train staff, and all of the other issues. And what we're seeing is this whole taking on the world by hepatology and specialist units with stretched staff who are under capacity for the work that they are doing, trying to think how they're going to deliver all of these services in the community. They don't need to. There's a lot of providers being set up to try and help, but we have as many barriers getting in to the system to try and support and give it better access to community diagnostics and better blood tests than there are as many coming out. So we really do have to think smarter to deliver smarter. Every point raised has been absolutely fabulous, and it is wonderful to see this spreading around the world and people raising the same issue. But unless you've got it on Medicare, unless you've got access to it, and unless you get the right blood tests to actually start to stratify at all, it's going to be very, very difficult.
Louise, you didn't mention today, and I love the points that you raised for sure, what's happening right now. What you didn't raise, which is a benefit that you've shared before, is the educational opportunities with patients when they see the liver scans and being able to monitor their progress as a goal, right? I don't know, maybe if you want to elaborate a little bit on your findings from that.
Yeah, we do patient questionnaires. It's part of CQC saying we need to get feedback on our services, what patients like, what patients don't like. And I've always found it far better to look at the complaints of a service. When I was a matron in the Excel Centre, I wasn't worried about all of the ticks that our service of vaccinations was perfect. It was the comments at the end of the suggestions, the real things that people wanted to see that were different or where they were positive. That's how we were able to change the service to work it better. 92% of everybody we engaged with who've sent the questionnaires back, and this is across enriched populations as well as non-enriched, have said that the use of FibroScan will help them make changes to their lifestyle and better make decisions. 7% then, further 7% said they thought it might, so it was maybe it will change. And only 1% of patients said none, it won't. So when you have a diagnostic device put into the hands of a skilled practitioner that can talk liver health quickly and non-discriminatory, because we don't discriminate what you've come in with, we just scan the liver and then we talk about what we find. But if you can say that 99% of people are affected by what they see and what they engage with in that room, then you are talking about one of the best devices to educate. But it can't be do the scan now and educate in 6 weeks when you see somebody for the results. It's got to be in that room at the time when they say, oh, I've got a bit of fat in my liver. What can I do about that? Because I don't want increased risks for heart attacks. It runs in the family or blah, 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 blah. So it opens up a whole new conversation. And then you can tweak out alcohol, food, high sugar fructose, all those things. Everybody has a little sneaky treat and they smile when they go, oh, I know what I've just done. And I said, what did you just think about there? Because that smile tells me you know what what it is. And it's funny.
Yeah, Roger expressed one of the concerns that's shared, and Jeff knows it also, that if too many patients are identified quantify what it's going to do to the system. But at the same time, if you're using the clinical care pathways, not everybody's going to be referred anyway. And the people that do have a liver health assessment, even if they're not referred, that is something that can be done to help other than just say diet, exercise. This is an internal driver that is really needed. I had that 319 CAP score, even though I didn't have fibrosis. I got, holy, you know what? I said, I got to do something about it. And it actually, like a year later, you can make a difference if you try. And, you just shared some of the reasons that it doesn't work always, but at least people know what they're doing.
If it doesn't work, though, you then go to the next step and we look for reasons it doesn't work. That could be genetics. That could be medication that we can't change. For a long time, methotrexate, and the school's still out on whether or not it does do damage or doesn't do damage. And certainly at Imperial, all of our consultants from dermatology and rheumatology referred anybody being considered for methotrexate to check the underlying liver health. Because if we can alter your diet to help you stay on the best medications for your condition and your lifestyle, then that maximizes your health around a condition that you've got. And we see multiple patients who've been cured of hepatitis C, particularly if you're genotype 3 and an Indian ethnicity, develop fatty liver following hepatitis C treatment and eradication. So it's not that you can just discharge these people. Sometimes they go on to have different forms of poor liver health that could still drive disease. So it's a more general awareness of liver health rather than think. But as GPs hear more people say, I think I might want to be screened for this. I've got type 2 diabetes, I've got hypertension, I've got high cholesterol. Then they might start to go, oh, well, we'll start to ask those questions. So chicken egg scenario in some extent, but GPs respond to what comes through the door, particularly in a lot of countries. That drives what they're going to do next. And doing that is key for me, that education.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, we will celebrate Stephen Harrison with some of the key opinion leaders who knew him best. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.